All right. Well, thank you so much to everybody for calling in to this roundtable of the Community Health Systems Initiative Roundtable series. It's our pleasure today to have Henry Perry here so that he could talk to us more about the census-based, impact-oriented methodology. Henry Perry is a senior scientist in international health at Bloomberg School of Public Health, and he was kind enough to agree to come and tell us more about this very interesting and powerful methodology for including communities in the production of their health. So, before I get into a conversation with Henry about this methodology, I just want to couch this a little bit in a sort of broader history, which Henry will speak more about, and also a new zeitgeist that is rising. Of course, everybody knows that after Alma-Ata, community health was seen as central to the production of health, but how to actually make that operational was not always clear. And through the years, people have spoken about community participation, community involvement, community action for health. But now, more recently, there's a renewed interest in community health. In fact, so much so that a recent World Bank document, a book actually, named Improving Health Service Delivery in Developing Countries from Evidence to Action, has an entire chapter on this topic, what they call community empowerment. And it's a sort of meta-analysis of the best available literature, including randomized controlled trials, around how to empower communities to participate in the production of their own health. From this, they were able to hone down a number of sort of take-home points that they consider to be essential and most successful in actually involving communities in their own health. And that's providing training for local health workers, providing communication and collective action by communities, supporting community ownership and management of services, and holding service providers, officials, and private organizations accountable to the services that they say that they're going to provide. So those 4 take-home points, I think it's important to remember, because we're going to hear this that's now seen, at least by this World Bank document, as being central to community participation, community empowerment. And yet, nothing new under the sun. Community census-based, impact-oriented methodology has been around for decades. It's currently being used by a handful of organizations throughout the world with great effect. In fact, right here we have Mario Valdez and Jane Thibodeau from Cura Americas, a group that Henry has collaborated with for many years in Guatemala. And they'll be able to tell us a little bit more, too, about their program and about how they use CBIO. So, Henry, thank you so much for being here.
Well, thank you, Daniel. It's great to be here. Thank you for inviting me.
Great. So jumping right in, so tell us a little bit more about the key elements of CBIO and maybe a little bit of its history.
Okay, thanks. CBIO is an approach that's not widely known about, but I'm passionate about it. Every year I get more passionate about it, and I think it's got a lot of relevance for global health for many reasons. It comes out of a very rich lineage of innovative thinkers and leaders in global health, but it never has really hit the mainstream. It really goes back to the 1930s when a man named John Gordon, who later became professor and chair of epidemiology at Harvard, started home visitation for surveillance in Romania back the 1930s, and that experience convinced him that home visitation is a key epidemiological tool, but it got extended into programming in India back in the 1950s when John Gordon worked with one of his students at Harvard named John Wyon to implement something called the Khanna Study, which was a groundbreaking piece of what I call community epidemiology. It was in the late 50s and early 60s. They spent about 10 years testing the first field trial of a family planning program. But in the process, they provided services in the home and visited every home and collected a lot of information. It was a research project, but it provided the foundation for a lot of other important work later. Carl Taylor, who was also at Harvard back in the 60s and later came to Hopkins to found the Department of International Health in the 1966, I think it was. He, in the 60s and 70s, started a groundbreaking project in North India called the Naringwal Project, which built on many of the ideas that are now CBIO. And through his mentorship and leadership, various other seminal projects were established at various places around the world. The Jamkhed Project in central India is world famous as one of the early pioneering programs to use community health workers. Search, also in central India, established by the Bangs, is world famous for their pioneering work and community case management of pneumonia by community health workers and home-based neonatal care. And also the Hospital Albert Schweitzer's work in community health, led by the Bergrens, which began in 1967. All of these were directly influenced by this lineage of ideas that grew from these field projects. And I got drawn into this in 1979 when I visited the Hospital Albert Schweitzer and had studied with Carl Taylor as an NPH student in 1970 and 71. So when I saw this in action, I knew this was something important. And as I started my own work in Bolivia, I got to know John Wyon and became good friends with the Bergrens. And so out of our work in Bolivia from 1981 moving forward, we gradually consolidated these principles, and they grew out of our work there, but also were informed by this rich experience. So the basic principles of CBIO are, number one, the overarching goal is to improve health in a geographically defined population, and also to measure whether or not you have actually improved health. And then closely related to it is the idea of doing this in partnership with communities and building a relationship of trust with communities, which involves responding to their needs as they see them, but also proactively addressing epidemiological priorities as the practitioner defines them and comes to understand them, which is hard for communities to do on their own. Built into this is a fundamental strategy which I call routine systematic home visitation. So that goes back to the early history of all this. Routine systematic home visitation is an opportunity to carry out surveillance. It's a very powerful surveillance tool for registering vital events, among other things. But it's also a powerful service delivery tool, and it's becoming more powerful every day as we get more and more evidence about the kinds of interventions that can be delivered at the household level, from education to community case management and so forth and so on.
Well, this is great, Henry. And you know, I want to jump in here to try to ask a few more questions about how this system looks like on the ground, you know, with dust on the boots. Because it's I think it's a lot of the ideas are very powerful, and a lot of people would recognize the benefit of routine systematic home visitation, although it's not, I think, the way health systems have been developed in a post-privatized world, a post-neoliberal world where so much was based on going back to hospitals and facilities and things that you could reimburse for. I think a lot of non-governmental organizations, especially the type that participate in this Community Health Systems Initiative, will recognize that home visitation is really where you unlock a huge amount of information, opportunities, and relationships with communities. So maybe tell us a little bit more about, what it looks like on the ground with dust on the boots.
Right. Well, I think maybe this will be a great moment for my colleague Mario Valdez to describe what he has led in Guatemala. But before I do that, let me just make a quick comment and say that there's a variant of CBIO that has become very powerful in the NGO community, and Cure Americas itself has drawn it into its CBIO approach. And so Mario will describe this, but it's called care groups. And care groups involve having a supervisor, low-level supervisor, who meets with a group of 10 volunteers, each of whom is responsible for 10 households. And then those volunteers visit that household every 2 weeks and convey a message about health behavior, utilization of health services. And then they meet after 2 weeks, talk about what they did, and they also register vital events. And so it's kind of a simplified form of CBIO. It doesn't involve all of the principles, but it's a lot of them are embedded in there. And so Cure Americas has combined the care group approach with CBIO in Guatemala and its other programs in other countries. So I'd like Mario to share with us what he's been doing for more than a decade now. And he has a translator named Jane Thibodeau, and Jane works with our Cure Americas office in Raleigh, but is in Guatemala right now. So, Mario, please share with us how you have implemented these principles on the ground in a very difficult, isolated highland area in the northwestern mountains of Guatemala with indigenous people, where communities are far from the road and don't speak Spanish.
Sí, buenos días.
Buenos días.
Buenos días, Mario.
Hablar con ustedes sobre las dos metodologías.
I'd like to talk to you both about the two methodologies.
Pues en el caso de Guatemala, aquí en la región de las montañas, hemos dado cuenta que las dos metodologías han ayudado a mejorar la vida y a disminuir también la mortalidad materna infantil.
So in the case here in the rural mountains in Guatemala, we've seen that the methodology has helped to reduce the mortality and to improve the nutrition of the kids.
Las dos metodologías son complementarias.
The two methodologies are complementary.
En el caso de la metodología de base comunitaria, se inicia con empoderar a las comunidades a través de sus autoridades.
With CBIO, it starts with empowering the communities so that they have a voice and they can make decisions about their own health.
Es un proceso que es un poco lento, pero que da resultados.
It's a process that's a little bit long, but that really works.
A un principio, la gente tiene dudas porque muchas veces no se le ha tomado en cuenta.
So sometimes in the beginning, people doubt the methodology because they don't realize the changes that are happening.
Pero cuando entiende los pasos que tiene que dar, comprenden de que tanto la participación comunitaria como el apoyo institucional ayudan a mejorar los indicadores de salud.
So when they realize that community participation and la participación institucional and institutional participation starts to help their health, then they get on board with the project.
Nosotros hemos tratado de facilitarle a través de 5 pasos que generamos conjuntamente con la comunidad.
So we've been working with 5 steps that we do in conjunction with the community.
El primer paso, que es muy importante, que es cómo generamos confianza.
Is how we create trust.
¿Cómo trabajamos en equipo?
And how we work together as a team.
Este paso hay que desarrollarlo, hay que generar elementos para que veamos que tanto la comunidad como la institución pueden trabajar en forma conjunta.
So there's a lot of work to develop a relationship so that the community can work with the institution that's doing the program so that they can work together as a team.
El segundo paso que va en relación a cómo en forma conjunta también se hace un diagnóstico con la comunidad.
The second step is working together to do a diagnosis of the community.
Y se identifican necesidades comunitarias, pero también necesidades epidemiológicas.
So they identify community needs as well as epidemiological needs.
De forma conjunta se pasa a un tercer paso que es la elaboración de un plan.
Working together, they move to step 3, which is creating a plan.
También se trabaja en un cuarto paso que es la parte esta de monitoreo y supervisión en forma conjunta entre la comunidad y la institución.
Step 4 is monitoring and evaluation, which they do together in a team with the community and the institution.
El quinto paso que generalmente es cómo celebramos nuestros éxitos, pero también nos animamos a tener otras metas, a nuevos retos.
So step 5 is celebrating the work that you have done, but then also looking at how you can continue to create new goals and improve the health of the population.
Esto es un ciclo simple, pero cuando tenemos la dinámica, muchas veces también hay ciclos complejos en los cuales ya tratamos no solamente la comunidad, sino también con el apoyo de la institución. Es decir, esta descripción de los 5 pasos es en una forma simple, pero ya en la realidad muchas veces se vuelve un poquito complejo, pero es donde tenemos que tener fortaleza tanto la comunidad como la institución.
Okay. So he says, like it sounds really simple describing it, but in reality it can be very complex with lots of different elements from both the institution and the community. So you really have to work to strengthen both sides so that they can continue to work together.
En este aspecto se logra la participación de líderes, de autoridades comunitarias y especialmente de los comunitarios que tienen cada una de las comunidades.
So it's really important to include like leaders from the community and different committees from the community so that they're all participating.
También se va trabajando por comunidad, pero luego por región y luego ya por municipio o un poco más allá.
So it starts out by working in a community and then grows to the region and then maybe a larger region like the municipality.
En el caso de la metodología de grupos de cuidado, se trabaja mucho con las madres y con las mujeres.
So, talking about care groups now, they work a lot with the mother.
En ese sentido también se va empoderando a la mujer a que también participe y se logra la equidad, digamos, del aspecto de género. La participación de la mujer.
Okay. So this is really empowering to women by involving their participation in their health.
Cuando hacemos las asambleas comunitarias, unificamos a hombres y mujeres y hablamos de lo que ha tenido resultado tanto en los grupos de cuidado como en la metodología de base comunitaria. En las asambleas, en las reuniones donde está toda la gente, hablamos de los resultados que tienen las dos metodologías.
Okay. So when they have community meetings, they talk about the results from using both of the methodologies.
Y es muy importante también compartirlo de los eventos vitales, porque ellos van conociendo a los aspectos de, en este caso, los nacimientos, las detenciones, migraciones que tienen también.
Yeah. It's really important to share vital events when you have community meetings, like birth and migration, so that they understand all those things.
Es un resumen corto de las dos metodologías.
That's a really short summary of both of the methodologies.
Perfecto, muchísimas gracias, Mario. Thank you, Mario, for that. Tengo una pregunta sobre eso, porque yo creo que los que están escuchando probablemente quieren saber algo más a fondo de cómo se ve día por día, ¿no? Día al día, cómo es que ese sistema se desarrolla o cómo está hecho en hechos. Por ejemplo, no sé si ustedes nos pueden explicar un poco de cómo se ve un día como en el trabajo en el campo. ¿Qué es lo que ustedes hacen? Por ejemplo, visitando a las casas o como trabajando con los grupos. ¿Cómo se ve? I'll translate. Thank you, Mario, for that. Can you tell us a little bit more about what this looks like day to day on the ground? How is this done with specific actions? Hi, Henry.
Yeah, I don't know what happened. Let's see.
We might have lost them for a second, but while we're waiting for them to come back, and we'll get a little bit more of a sense of what it looks like on the day-to-day for them, tell us a little bit more about how you've seen this work in other areas and how you've seen it evolve through the years.
Yeah. Let me make a quick comment that goes back to sort of a follow-on to what Mario was saying. The empowerment aspect of this is one of the many, many strengths of CBIO, but I think in Guatemala they've done a great job, and I've seen this in other places too, of helping the communities collect this information, and the vital events are probably the most important part of it, collect it in a way that they feel ownership of it and they know themselves what the data is showing. This is a very empowering thing, and the whole idea of engaging communities to help them improve their health is a whole approach to global health that is still underdeveloped. It's the World Bank in this chapter you mentioned is getting at it, but I tell people all the time that our greatest resource in global health are the communities themselves, and we are only beginning to learn how to work effectively in unleashing that power and that potential that exists within communities to help them improve their own health. Public health has, for decades, considered communities as a target rather than as a resource, and so I think CBIO is one example of an approach that tries to build on the strengths that are inherent within communities, and it is definitely the case that you can't do CBIO unless you engage the community, involve them, and doing all the things that are involved in it. There's no way a program would have enough manpower, paid manpower, to do these sorts of things.
Well, this is, what you're saying is critically important, and to some extent, we have to think about why communities haven't been more involved in their health. Some of it might be, a question around power sharing and about who is able to kind of control the system and the resources around the way that system functions. That, I think, is starting to erode, hopefully, in some contexts. It depends on, I think, what central leadership is willing to model and then demonstrate. But then for the people who actually want to utilize these techniques and these ideas, a lot of times they don't have a functional way to do so. Like, for example, in this World Bank document, they talk about a couple of other points of advice. They say, share results with communities, which we heard very clearly from Mario that that's something that they do. Use systems for local adaptive learning, which I think that's done through this iterative process of community engagement. Harness community resources to support the program and promote equity. But again, even within those sort of titles of advice, there's so many different ways to do it on the ground. And I think it's very easy to get caught up in I think, problems. It's not always easy to involve communities. So, I don't know, can you tell us a little bit more about your thoughts about some of the challenges around involving communities and what you think are maybe some of the reasons why these ideas have gotten hitched up?
Yeah, that's a question. Well, one of the fundamental requirements for making this work is leadership. Mario Valdez is the kind of leader that understands all these things, knows how to work with communities, knows how to work with local people. He's deeply committed to the vision of this. In fact, he's developed his own version of CBIO on his own before he ever started working with us. Wow. So, unfortunately, people in ministries of health don't usually have those kinds of skills, and learning how to work effectively with communities is an enormous challenge for Ministry of Health programs. So I think that's one of the reasons that this has been slow in developing.
And Henry, the thing that's also interesting, to go back to this World Bank document, is that the presence of strong local leadership was also seen as one of the most important elements, and that's what you're seeing here.
Right. I call CBIO an example of community-oriented public health, or you could use the term primary health care if you wanted to instead of public health. But John Wyon, who taught at Harvard School of Public Health for many years, he was my mentor and came up with this idea of the three kinds of public health, but you could also, as I say, use primary health care instead of public health. But there are three kinds of public health. There's disease-oriented public health, there's services-oriented public health, and there's community-oriented public health. Everybody knows what the goal of disease-oriented public health is, to control tuberculosis and HIV and so forth. Services-oriented public health, the goal of this is to get essential and needed services out to people who need them. And then community-oriented public health, the goal of that is to work with communities to help them improve their health. And John liked to say that these are the three legs of public health, and they're like a stool, and if you have one very weak leg, then your whole platform for your stool is weak. And, we live in a world, my whole professional career, in which community-oriented public health has been a stepchild. It's been very weak, and I think we're on the cusp now. We're really developing this leg of public health, but it's so essential, and it's been so slow in coming. But it's great to see the interest in community health workers, and I'm very much involved in that in many different ways. But even just focusing on community health workers doesn't really get at the key principles behind CBIO, which are a little deeper than just a stronger link between public health principles and healthcare delivery than is found in this other lineage that many of us are connected to called community-oriented primary health care. But, we need stronger efforts in all of these to build them up and to fully achieve the potential that we know is there to improve the health of people with existing knowledge and technology.
So I want to ask another question about, and I'm going to couch this question with a little bit of a sort of insight to some of what happened in the United States when the idea around this third leg of community-oriented primary health care was being either brought in to the functional sort of implementation of programs or being left out. Jack Geiger was a physician who worked in public health and was centrally involved in the creation of the community health centers. And he was based out of Boston, created his model based on the Soweto model in South Africa. And through the years, many different programs, many different community health centers were created. In order to ultimately get federal funding, you had to have 51% of your board be members from the community. And that was, one methodology by which they were able to hopefully try to get communities involved. But ultimately, that may have been the way that community participation was pegged to reimbursements, or at least to federal funding. But really, the bread and butter, the day in, day out of running your program was reimbursements. And reimbursements were done based on, and this is also true for, throughout the United States healthcare system, is a procedure. If you do something, even, something with your hands, you get reimbursed, versus if you do something with your mind, less so, and if you do something with communities, not at all. So when I recently spoke to somebody, a friend from a community health center, they said the hardest part of their job was interacting with the 51% of the community members on the board. Part of that might be because the people who participate in that type of program might be, come with a certain energy. So, the question is, community committees, community health workers, systematic visitation. What do you think are the most powerful ways by which to involve communities? Also, having strong local leadership is also important. But beyond this, what do you think are the ways in which these ideas can get sort of, really grow roots into functional implementation?
Yeah. Well, I guess I would answer that, Daniel, by saying that, to me, engaging communities in their own community diagnosis using local data it's a very powerful process in terms of empowerment and self-awareness, but it's also an appropriate approach scientifically because using national level data or subnational data often doesn't reflect exactly what's going on in a smaller geographic area. And I've come across lots of examples of that over my career. And so using local data to guide programming, I think, is terribly important. And it can be done without a lot of technical support, without extra money. It doesn't require, high-powered, expensive surveys. And so engaging leadership, local community leadership in this process, to me, builds the foundation for something that can be very powerful and effective. One of the best examples of CBIO at larger scale that I know of right now is a program that BRAC has implemented in urban slum communities in Bangladesh, reaching 7 million people now. They don't call it CBIO, but all the principles are there. And they have had a dramatic impact on reducing maternal mortality and neonatal mortality through the process of community engagement, mapping, visitation to every home, census creation on a large scale in an urban slum environment, which most people say you couldn't do that kind of thing in a setting like that, but they've done it.
So I guess, for the people who are listening here, if they said, okay, I want to do more of this once I, get back to my program, I think probably some of the take-home points that we're giving them are, one, getting out to the households is critical. Community health workers, obviously, which people talk about, but also, like you were saying, in your monitoring systems and evaluation systems, not allowing the sort of micro-epidemiology of that might be very relevant to a local community to not get that sort of averaged out, the tyranny of the averages.
Right.
Where you say, listen, in this community, we realize there are these diseases, we have to do something about this.
Right.
So this is actually reminds me of a related question. It's always hard to know where to draw the boundaries around either the community or the disease that might be relevant to that community. So there are any one community, if you define it geographically, is actually going to have many sub-communities. That might be, disenfranchised people, the homeless, people who culturally aren't respected, like the untouchables or homosexuals, or maybe people who are politically of a party that are kind of left out. When we engage with communities, what's been your experience about how to avoid sort of the tyranny of the masses?
Yeah. Well, that's a great question too. I think of CBIO as a pro-equity approach in two respects. The first one is that since by its very nature it involves reaching to every household, that by itself it's a step towards equity. It's not equity because it's not giving special attention to specific underserved groups, but at least it's ensuring that everyone is engaged, which often is not the case in health programs. The second part of CBIO, which hasn't been as fully developed as it should, but it involves identifying with local data, high-risk groups. And one of the interesting things about public health to me is that the high-risk underserved groups are also the public health priority for a program because they're typically people who are at the highest risk of death or disease or disability, and therefore they deserve special attention. I think our experience in designing programs that target these groups for equity purposes is not as strong as it could be. Of course, a lot of our programs are focused on reducing child mortality, which is, I guess, an equity statement rather than reducing the mortality of everybody. But I think that we could do more with this. When I was at the Hospital Albert Schweitzer in Haiti, directing their program from 2000 to 2004, we found out that even though the hospital and its community health work had been very proud of reaching every home in the catchment area, we found out that the mortality in the mountains was twice as high as the undefined mortality as it was in the plains. About a third of the population lived in the mountains, and the people there were less educated, the houses were further away, and there were lots of challenges, but we had the same number of community health workers per population in the mountains that we did in the plains. And so what I came to realize is that to really achieve equity in that kind of environment, you need to invest, if not twice as much resources, maybe 4 times more resources in the mountains to really achieve equity. And as far as I know, they still haven't done that. But I think we published a paper on that, but it's a great example of how we need to give more attention to equity issues.
And, we heard similar themes when Alexei Matusik, whom I know you know and have worked with, when he spoke about his surgery community health worker program, about the difference between people in the mountains.
Same set of issues in the same location, right?
I once heard from a Cuban colleague that, in Cuba, the idea around community participation in health is very important, but it's often frustrating for people because they say, when it comes to community participation, someone else decides while we participate. Meaning, it's there's one question around how you get involved in the work, but then there's a different question about how much power you're given to help direct the work. And this is where I think sometimes it gets very difficult for people in that they might say, okay, I want to work with communities, but I'll go to their houses, I'll visit them, I'll maybe even find a few people with whom I can work, right, that aren't going to challenge me too much. But that, if you have a community that says we want to do something radically different, or you have a vocal minority, powerful minority in the community that says that we want to do something radical, something that's very much important to us, but that might not have a focus on equity. That say, okay, we want, for example, to push out these foreigners, this immigrant group that came recently. It starts to get this is where I think the real tension is. It's around power sharing, but then also agenda setting, and about, how we both avoid elite capture, which is one challenge of working with communities in which a small, powerful group might capture sort of the amount of power that's given out. But then also when you do share and the community and the participants might take it a different direction than you might have anticipated or agree with, and then you have to either go with it or pull back. Well, what are your reflections on a little bit of that tension, that difficult dynamic?
Yeah. Again, a great question. Well, built within CBIO is, first of all, the notion of what are the local epidemiological priorities. So that's based on data that's derived from visiting all homes and vital events data and so forth. So that's hard if it's done correctly, it's not something that's going to be subject to capture by local elites for their own interest. The second thing is that built into CBIO is the notion of combining local community priorities with the epidemiological priorities, and those two together make up the program priorities for what the project or the program is all about. And I think, although we don't specify in detail how you might assess a community's health priorities, it's pretty obvious that just talking with community leaders, the official community leaders, or the local influential people by itself is not going to provide you with a good picture of what the community's priorities are. Of course, women and children are always at the bottom of all this, so having a process for talking with mothers about what they think the health priorities are is terribly important, and a process for including marginalized groups for determining community priorities, I think, is terribly important as well, although we don't specifically talk about that in what we have written, but I think it is an important idea. So I think specifying further how one might go about defining what a community's priorities are, independent of what the epidemiological priorities are, is an area of further development, I think, of CBIO.
And I think what I'm hearing there, that is actually, I hadn't considered it as much myself previously, but this idea that, you know, with strong local leadership who can set a tone, a vision, and a process, that you try to use data as best as possible to guide the conversations so that it doesn't become sort of local ideology or it kind of can be perhaps a sort of distraction or leave people away from the possibility of elite capture. That's very powerful. I mean, you know, if data drove all decisions, the world would be a much better place. And I could imagine that, you know, local communities have probably as much of a tendency to avoid data, guiding decision making as much as national governments or even, you know, people's own households. Sometimes we like to ignore the things that we don't agree with, even if it's in cold, hard facts. Having said that, I think the local leadership is critically important. So one other question that I want to explore a little bit with you is this question around trust. Trust for me, in my experiences in community health, is probably one of the most important concepts, and I think one of the most ignored social goods around developing programs. But yet, when you talk to community members, it's probably the first thing that they talk about. When they choose which providers to go to, when they choose how to seek health care. You know, trust is not an easy thing to define. Luckily, there is a small literature around this. Dr. Nava Ashraf, who's a behavioral economist at Harvard Business School, wrote a paper, a very interesting one, called Decomposing Trust and Trustworthiness, in which they did a couple of different exercises with groups in 3 different countries, Russia, South Africa, and the U.S., to try to understand trust and sort of the mechanisms of trust. And trust, for example, is it something that's calculative? Is it based on expectations of trustworthiness? And is trustworthiness assumed to be reciprocity, which, you know, reciprocity being that if you see trust, you reward with trust, or if you see unkindness, you reward with unkindness. And then is trust really the sense of unconditional kindness that, you know, when you feel that, you generate a sort of trust? I mean, that's a lot of the sort of bones behind the mechanisms of trust. But what are some of your thoughts about how you actually generate trust with communities, how you actually have that confianza, which we'll hear communities speak about over and over again?
Well, I think you're absolutely right about the importance of trust. And of course, we read about the lack of trust in the newspapers with respect to the Ebola epidemic and the way populations think about their health system.
And vaccine programs and so many other.
and when I started my work in Bolivia, there was enormous suspicion towards me as an American working in a somewhat leftist-leaning country at that time. And so building trust with a very traditional group of indigenous Native Americans was a great challenge, too. So I've dealt with this personally. But I would say that from my perspective, building trust requires an ongoing relationship between a practitioner, that's a health program, could be the government or an NGO, an ongoing relationship between the practitioner and the community in which both sides are treated as partners and both sides try to understand the other side and both sides work to help achieve common goals, and that takes time, and that's what Mario Valdez said in the very beginning. This is a process that takes time, but once it gets going and the fruits are seen, it becomes very powerful. So in Guatemala, Cure Americas has been working down there more than a decade now, but the work and the procedure and the methods that are being developed are being noticed across Guatemala, and people are coming out to this very isolated place to see what's going on, and they're wanting to try this out in other parts of Guatemala. So that's kind of the organic grassroots strength of this that, to me, makes CBIO a very powerful approach. And in fact, from my standpoint, I got really sold on this on a deeper level when I saw the empowering nature of CBIO for our own staff in Bolivia when we were working on this, and as well as the communities also. So I think it's got a lot of power to it. It doesn't appeal to donors because it's not a selective approach and it's not a short-term approach, but I think the ideas are so fundamentally sound that I think it's got a future. So.
And you speak about that in the paper that you made available to us from Social Science and Medicine, in which, there was the comprehensive primary health care advocated for in Alma Ata, and then the selective primary health care, which became the favored approach by donors thereafter, and that CBIO is a sort of middle way.
Yeah, I think that's a powerful idea.
So what
it builds on the power of selective approaches, because you're addressing epidemiological priorities, which John Wyon defined as the most frequent, serious, readily preventable or treatable conditions, in a population. So that's the public health technical side of it. But by responding to community needs and interests, which generally in the healthcare realm are better curative care, you're mixing the power of selective approaches with the power of comprehensive horizontal approaches in a structured, well thought out way that will achieve results in improving population health if applied properly. And if you're measuring the results and you're not achieving the outcome of improved health, then you need to go back and redesign and redeploy, which is built into the CBIO process.
And it's a very nice and iterative process. So to start wrapping it up, CBIO is a very powerful methodology, and it hasn't gotten as much traction as it probably should have. People often say that they want to include communities more, but don't have a way to actually do it in a reproducible way. Here is one such way. In the future, if programs were going to implement this, or if governments were going to take this on as policy, or if donors were going to start funding it, what do you think are ways in which this methodology could become reproduced all over? I mean, it sounds a more iterative, careful process. It requires local leadership, which sometimes is the human resource question is one of the most difficult, especially when you have a very robust private sector that's pulling a lot of leaders away from community health work that may be under-reimbursed. I mean, traditionally, of course, donors can decide to reimburse whatever they want. But so what are some ways in which you think that CBIO can actually be implemented and adopted on a larger scale?
Yeah. Well, that's a great question, Daniel. I think one approach is to enable people to go and visit programs where these ideas have been implemented successfully. And as I said before, there are other programs out there that don't use the term CBIO that, in fact, are using these principles. So I think visiting other programs is good. I think, as we emphasize in the paper, I think starting very slow and a very small scale and gradually building this up has a lot of power to it. And so I would recommend that as well. Engaging with leaders who have done this before and have a deeper understanding of it is another important part as well. And, of course, we should be publishing more about this. I feel guilty about this as an academic that I haven't been more effective in getting more of this out into the scientific literature.
Giving something an acronym and packaging it into sort of a set of tools is one powerful way by which to make it modularly increase in influence and exposure. And Core Americas has a very nice webpage where you can download, and the core group has a lot of these tools readily available. At the same time, if it's heartening at all to those of us who care about this stuff, I think a lot of programs do implement pieces of this. Like you were saying, BRAC might not call it CBIO, but it looks like it. And this idea of the model project that people can experience, and then once they get that taste into their mouth, they can never wash it out. I think that's also a very powerful idea, and I think a lot of groups implement that too. For me, if it's only increasing the ways in which we can get local leaders to participate in priority setting and we create systems for sort of nimbly responding to how programs look like with local epidemiology and getting out of facilities and going to homes. If we only do that, then we've taken, I think, some of the best parts of CBIO and made them sort of the modus operandi of global health in general. Would you add any other activities or tasks to that list?
Oh, I agree with you 100%. I think that's a great start, and I know that you've been working with hypertension, and I think that's a great example of an epidemiological priority that communities themselves may not be aware of. So I think focusing on specific high-impact interventions and then using them as an entry point for CBIO is a great idea too. Home-based neonatal care is a very powerful tool. There are other interventions out there. So I think sort of using those as an entry point, but using a CBIO-friendly kind of approach to getting those going and then building from them makes a lot of sense to me.
And then also decentralizing care and having so it's comprehensive packages, so comprehensive care delivery. It's decentralizing care and decentralizing power around that care. I think it's a really wonderful broadening of, I think, what global health has traditionally thought it can do and what it's been bold enough to do. So, Henry, I really appreciate you taking this hour to talk to us and to walk us through these ideas and start to give some, wisdom about how this can become not just something that has been of interest through the last couple of decades, but will be critically important for moving forward. Any final thoughts or words as we wrap up?
I tell people that learning how to work with communities to help them improve their health is at a point now where the practice of medicine, that is a doctor caring for a sick patient, was 100 years ago. We're on the threshold of some very exciting innovations. I think CBI was one example, but we need a lot more of this. But we're building a science for how to work together with communities to help them improve their health. And I think we need to encourage more research and experimentation in these areas, and it's an area that's going to have great fruit as we move towards achieving health for all, hopefully by the year 2100. We didn't achieve it by 2000, so we still have a long ways to go.
Wonderful. Thanks so much, Henry. And I'll leave us with a quote, which I know you'll recognize, and it's one of my favorites, by Carl Taylor, when he said, "There is no universal solution, but there is a universal process for achieving an appropriate local solution."
Right.
And I think that that's encapsulate a lot of what we're talking about here. So fantastic. Thanks much.